Hey everyone, welcome back to another medical coding review. Today we're going to go over the endocrine system and the nervous system. So this coordinates with chapter 14 of the CPC curriculum. Now again, as a reminder, this is a review. It is not an introduction to or a beginner course for this section of medical coding. It is for those that have already studied medical coding and want a little bit of a focus just on this particular chapter, what codes are involved, what are the key things to look at, and then we go over a couple of cases. So let's get into it. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. Today we're going to go over the endocrine and nervous system. So we're going to cover what's in CPT, what's in ICD-10, and then we'll go over a couple of sample questions that are similar to some things you may see on the CPC exam. So let's start out with some of the CPT sections. Now this one is not going to be in order just because of the way I wanted to organize them on the slide. So we start with our skull, meninges, and brain, and there's a lot of different stuff in this particular section. So we have injections, drainage or aspiration, and then we get into twist, drill, burr hole, or treatment of the skull, meninges, and brain, craniectomy, and craniotomy. So ectomy meaning removal, otomy meaning going into, incising into. And then we have surgery of the skull base. We have approach procedures, so anterior approach, middle approach, and posterior approach, and then definitive procedures, base of anterior cranial fossa, base of middle cranial fossa, and then base of posterior cranial fossa. So location as well as approach. And then we have repair and or reconstruction of surgical defects of the skull base, endovascular therapy, surgeries for aneurysm, arteriovenous malformations, or vascular disease. Then we have stereotaxis, stereotactic radiosurgery, neurostimulators, repair and neuroendoscopies, and then cerebrospinal fluid shunts. After that, we're into the spine and spinal cord, so incision, drainage, or aspiration, just like on the other side. But then we have catheter implantation of the spine, endoscopic decompression of neural elements and or excision of herniated intervertebral discs, posterior extradural laminotomy or laminectomy for exploration or decompression of neural elements or excision of herniated intervertebral discs, transpedicular or costovertebral approach for postolateral extradural exploration or decompression, anterior or anterior-lateral approach for extradural exploration or decompression, lateral extracavity approach for extradural exploration or decompression, and then we have incisions, excisions by laminectomy of lesion other than a herniated disc. Then we have excision anterior or anterior-lateral approach, intraspinal lesion, stereotaxis, stereotactic radiosurgery, neurostimulators, so spinal neurostimulators, repair, shunts, and then spinal cerebrospinal fluid. Next in this particular chapter of CPT, we have the extracranial nerves, peripheral nerves, and autonomic nervous systems. So we have the introduction or injection of anesthetic agents, diagnostic or therapeutic, somatic nerves, paravertebral spinal nerves and branches, autonomic nerves, neurostimulators in the peripheral nerves, destruction by neurolytic agent or chemodenervation, somatic nerves, and sympathetic nerves. Neuroplasty includes things like your carpal tunnel repair. Then we have transection or avulsion, excision, somatic versus sympathetic nerves. Then we have neuroraphy, so if someone maybe lacerated their finger and they lacerated the nerves, we have to suture the nerve back together. And then neuroraphy with a nerve graft, vein graft, or conduit. Other procedures. And then this endocrine system actually comes before all of our nerve codes in CPT, but I wanted to kind of just stick them here because they look just a little bit better on the slide. So endocrine system, we have our thyroid gland, incision, excision removal, and then our parathyroid, thymus, adrenal glands, pancreas, and carotid bodies, either excisions or laparoscopies. So for ICD-10, our endocrine is going to be a lot of our chapter 4 codes, disorders of the thyroid gland, diabetes, that is a huge one. When a patient has diabetes and the provider doesn't specify what type of diabetes they have, we always default to type 2 diabetes. So if they don't say if it's type 1 or type 2, we default to type 2. Other disorders of glucose regulation and pancreatic internal secretion, disorders of other endocrine glands, intraoperative complications of the endocrine system, malnutrition, other nutritional deficiencies, overweight, obesity, and hyperalimentation, metabolic disorders, and then post-procedural endocrine and metabolic complications and disorders that are not elsewhere classified. Also, another thing to keep in mind as it relates to specifically diabetes as well is we talked about those Chapter 15 pregnancy codes. They always take sequencing priority. So if it's gestational diabetes, we want to use one of our O codes, and that will take sequencing priority. The other thing to note here is those E65 through E68 codes for overweight, obesity. Those need the associated BMI codes for them as well. And then our Chapter 6 is our diseases of the nervous system. So we have inflammatory diseases of the central nervous system, systemic atrophies primarily affecting the central nervous system, extrapyramidal and movement disorders, other degenerative diseases of the nervous system, demyelinating diseases of the central nervous system, episodic and paroxysmal disorders, nerve root, and plexus disorders, polyneuropathies and other disorders of the peripheral nervous system, diseases of myoneural junction and muscle, cerebral palsy and other paralytic syndromes and other disorders of the nervous systems. We'll talk about the non-dominant versus dominant for hemiplegia and hemiparesis. And one thing also that I should mention is things like pain is very big in the nervous system. And when we are talking about like post-operative pain is only coded when it's related to a complication. Like after you have surgery, it's kind of expected that you're going to have some amount of post-operative pain. So we don't just code that pain unless it's something related to a complication. And that's why they're having an abundance of pain or a different type of pain that is outside of what is routine for that procedure or that surgery. So the hormones created and released by the glands in your body's endocrine system control nearly all of the processes in your body, and these chemicals help coordinate your body's functions from metabolism to growth and development, emotions, your mood, your sexual function. They can even help with your controlling of your sleep. Now, physical and emotional stress can cause the endocrine system to produce more hormones, and that increase of those productions when you're having prolonged stress can actually cause endocrine disorders, even things like obesity. And you've probably seen some of those commercials that they have on TV where they talk about how stress releases the cortisol and the cortisol goes into your belly. Well, there is some backing to that. The additional stress from that strain on your endocrine system can in fact cause you to gain more weight. Now, the nervous system is made up of your brain, your spinal cord, and all of the different nerves of your body. And the nervous system controls everything you do: breathing, walking, thinking, feeling. The nerves basically carry the messages to and from the body so that the brain can interpret them and take action. Maybe things like moving your muscles to make your body move, or if they feel something like, oh, they sense pain, and they say things like, hey, take your finger away from that hot plate that you accidentally put your finger on. That is your nervous system sending that signal to the brain going, hey, that's hot and it hurts, move your finger. Now, this is one of my favorite concepts to cover, and that's the term with. And even though this isn't a chapter specific guideline, it does come up a lot in the endocrine system because we talked about those diabetes codes, right? So if you look at this coding guideline with the term with, it says the words with should be interpreted to mean associated with or due to when it appears in the code title or the alphabetic index. It also says the classification presumes a causal relationship between the two conditions linked by these terms in the alphabetic index or tabular list. And these conditions should be coded as related, even in the absence of provider documentation explicitly linking them. Now, what the heck does that mean? So let me show you. So here's our alphabetic index, and here's the word diabetes. And if you'll notice, the first thing that comes in the indentation following diabetes is not the right alphabetical term, it's the word with. And that's because of that assumed cause and effect relationship. So any word that appears here under the term with, under diabetes, is assumed to be related even if the provider does not specifically state that they're related. The only way that they would not be coded as related is if the provider specifically states that there is something else, some other reason that's causing that these are absolutely not related. So even if the provider says diagnosis 1, diabetes mellitus. Diagnosis 2, gastroparesis. That gastroparesis is under this term with under diabetes. So they are assumed to be related. And instead of coding just the code for gastroparesis and coding our good old-fashioned E11.9, we would use this more specified type of diabetes code, E11.43. Same thing if the provider says diagnosis 1, diabetes, diagnosis 2, gangrene. Gangrene is under this term with, so that's assumed to be diabetic gangrene. So we don't look up diabetes and assign E11.9 and then look up gangrene and assign the code for gangrene. We use this combination code E11.52. Now, however, that doesn't mean that that's it. You just need that combination code, because sometimes you do need an additional code to add some additional type of specificity. So for example, diabetes with chronic kidney disease, even though we have a combination code that's diabetic chronic kidney disease, this doesn't tell us the stage of that chronic kidney disease. So you would need an additional code to tell you the stage of the chronic kidney disease. Now, the nice thing is if you look up code E11.22 in your tabular list, it will tell you, hey, use an additional code to identify the stage of the chronic kidney disease, and it'll give you the little range of codes that you're supposed to use for that additional. And when it says use an additional code, that means we use this code first, and then we add on, meaning it goes sequenced after that code to identify what stage of that chronic kidney disease is it. Now, in our ICD-10 Chapter 6 guidelines for the nervous system, one of the things to think about is that dominant versus non-dominant side that we see for hemiplegia and hemiparesis. And there is an assumed default for dominant versus non-dominant when we don't have the indications. So if it's a patient and their right side is affected, but the provider doesn't say if the right side is their dominant or non-dominant side, we default to dominant. If it's the left side and it doesn't say that it is dominant or non-dominant, we default it to non-dominant. For ambidextrous patients, and they don't say, the default is dominant. If you kind of think about right-handed versus left-handed, if you don't know, you're going to assume automatically that someone's right hand is probably their dominant hand and their left hand is probably their non-dominant hand, just because that's how it works for the majority. Same kind of thought process with hemiplegia and hemiparesis. We're going to assume that your right side is dominant and left side is non-dominant, and of course, if you're ambidextrous and can do either, we're going to assume it's dominant. Now let's go through a couple of sample cases. So here we have assessment and plan. Number 1, diabetes. Number 2, chronic kidney disease, stage 3A. And number 3 is a left foot ulcer. So we're starting right away with those diabetes codes that I talked about, how we have that assumed cause and effect relationship. So here we have diabetes with, and we have diabetes, and those are both on there, the chronic kidney disease and the foot ulcer, right? E11.62. So let's head over and see what we can do here. So let's take a look here. Assessment and plan, diabetes, and then we have an assumed cause and effect relationship between chronic kidney disease and the left foot ulcer. So foot ulcer, there we go, E11.621. So we can pretty much assume that the ones that are going to have unspecified diabetes, which is E11.9, like those are out. So right away, we're going to eliminate B as a potential option. We're going to eliminate D as a potential option. Now, if you look here, this is an E11.22. This is an E10.22. So another thing to point out, these are all for diabetes type 2. There's actually a section for the type 1 assumed relationships. So that's here under our type 1. So this says diabetes mellitus. It doesn't say that it is type 1 diabetes. So actually that right away even eliminates our option C. But just for the purposes of demonstration, so if we have our diabetes mellitus, we're going to assume our cause and effect relationship between CKD as well as the foot ulcer. So we're going to use not our E11.9, we're going to use for the chronic kidney disease code, E11.22 for chronic kidney disease. If you look up E11.22, in the tabular list, it will tell you to use an additional code for the to specify the type of chronic kidney disease, because even though this tells us diabetic chronic kidney disease, it doesn't tell us the stage. So this code here, N18.31, verifies that stage for us. So that is the stage 3A of the chronic kidney disease. Now we also use E11.621 for diabetes with the foot ulcers. We can use as many codes as needed to define the different types of diabetic complications that a patient has. The only thing we can't do is use E11.9 unspecified diabetes, and then you also use a specified type, because it can't be unspecified and specified at the same instance, right? You can't say it was unspecified, but then also say, oh yeah, it was diabetic nephropathy, because that's a specified type, right? So, but you can use diabetic nephropathy, and you can use diabetic hyperglycemia and diabetic gangrene if the patient has all of those conditions. So when you look up E11.621 in the tabular list, and let's do that right now actually. So when you look up E11.621, it's very kind to us, and it tells us use an additional code to identify the site of the ulcer. So it wants to know basically, where is this ulcer? So even though we know it's a diabetic ulcer, we want to know, is it the right or the left? Where the heck is it? And it gives you the different code ranges to even look at. So that's what that L97.529 code there is. That is to identify that this ulcer is on the left foot. So this one here, our answer is A, our diabetic chronic kidney disease with the stage 3A for the N18.31, and then diabetic foot ulcer is E11.621, and then L97.529 designates that it is a left foot ulcer. Next, we have preoperative diagnosis, right carpal tunnel syndrome. Post-operative diagnosis is the same. A small incision over the right carpal tunnel was made over the palm and wrist, cutting through the palmar fascia and exposing the carpal ligament. Ligament was divided to release the median nerve. Surrounding nerves and tendons were intact. Subcutaneous tissue sutured 2O vicral and 3O nicral to the skin. So what are the key words that we're going to pull out of here? Well, we're going to pull out here that it is a right carpal tunnel, and they did the release of the median nerve of the right carpal tunnel. So how do we want to try and do this one with our CPT? Do we want to look up release? We could try that. Let's see what happens when we look up release. So if we go under release, right under there is our code for carpal tunnel. So there's no questioning it. That is our right code, 64721. Now the one thing we have to consider though is what? Our modifier. Because 64721, let's look it up. We have neuroplasty endotransposition median nerve at carpal tunnel. And this doesn't say bilateral, so we want to designate, is this the right or the left carpal tunnel? So we're going to need an RT modifier. So we can tell right away 50 is our modifier for bilateral, and that wasn't bilateral, it was the right carpal tunnel. This one is the wrong one. That looks like it's ulnar nerve at wrist, and that's not where we were. And we have 2-1, so yep, this one was out. And then, yep, we have answer C, 64721, which is our neuroplasty endotransposition and median nerve at carpal tunnel, and our RT modifier to indicate it was the right side. Next, what CPT code is used for a unilateral partial thyroid lobectomy without ismethectomy? So we have 60500, 60210, 60520, and 60220. So those are all pretty kind of close in proximity. So we have it is a partial thyroid lobectomy without ismethectomy, which tells me the fact that there's an ectomy here means it's a removal. So we're removing some of what? We're removing some of the thyroid. So we probably want to be in our excision section of our thyroid gland, right? Because that's what we're doing. We're excising part of the thyroid gland. So we have biopsy, excision of cyst. Here we go. This looks a little bit closer. Partial thyroid lobectomy, unilateral, with or without ismethectomy. Isn't that what we did? Partial, right? Thyroid lobectomy, unilateral, with or without ismethectomy. Yeah, that looks like it's the right code for us. 220, that's a total, and we didn't do a total. We did a partial. And those 5 zeros look like they are in the section for the parathyroid. And this wasn't a removal. Yeah, this is a thymectomy. And a parathyroidectomy. So we didn't do that. We did a partial thyroidectomy. So this is this 60210 code. Interesting thing about this with or without ismethectomy, that basically means if the provider did it or they did not do it, it's still the same code. So with or without, if they did or did not do this ismethectomy, it would still be the same code. By the way, if you're enjoying this type of content, I would love it if you give the video a thumbs up. Don't forget to subscribe. Hit that notification bell so you can get alerts when I post new episodes. Let's do one last one. A patient is evaluated in the ER for an injury to the left middle finger. It's determined the patient needs a repair and the ulnar digital nerve is sutured in the operating room with the use of the operating room microscope. So I'm seeing a couple of things to pull out of here. So let's see. It was the left middle finger. They did a repair of the ulnar digital nerve. It was sutured. What's our suffix for suturing? Raphe, right? So we're probably doing a neuroraphe or suturing of the nerve. That's what I'm thinking is the term that we're going to look for, a neuroraphe of the ulnar digital nerve. And they also use this operating room microscope. Now that's something you have to kind of be careful with because many times in procedures, they kind of expect you to use the operating room microscope. So in many procedures, it's bundled in, but sometimes not. I kind of have that code memorized. It's 69990. So that's something you may want to check for CCI edits for. Now, if you're taking the exam, you don't have a CCI edit checker. So you just have to kind of rely on either CPT guiding you a little bit about you do or do not use that operating room microscope. Sometimes they do give you information and clues within the context of that code. Sometimes you can tell just by the depth of that procedure that it's something that they're likely going to use the operating room microscope for on a regular basis. The other thing we can look at here is, look, we've got some different modifiers here. So these are our finger modifiers, our F2 and our F7. Those are finger modifiers. You can find those anatomical modifiers in the beginning of your CPT book. So if we look here, F2 is the left hand third digit, which would be the middle finger. So you do kind of have to know the difference between the digits versus if it's an index versus the middle finger, etc. I used to do a pretty good amount of hand surgery and I didn't want to get tripped up, so I actually used to write on my CPT book which one was the index finger, which one was the pinky, which one was the ring finger, because my providers wouldn't say second, third, fourth digit, they'd say index finger, ring finger, etc. So F2 is our left hand third digit. F7 is our right hand third digit. So actually we can eliminate B right away because this was the left hand and we know that that is an incorrect modifier that we don't want to use. So B is out. If you were to look up this code 13131, that is actually a complex suturing code. So that would be suturing more so for the skin and subcutaneous tissue and doing a complex repair versus suturing of a nerve. So that's different from suturing skin versus suturing nerve tissue. So let's take a look at what we've got here, kind of thinking probably A or D. So we've got a difference here of 1 with the modifier, which I'm already kind of thinking I like that one with that has the modifier attached to it. So 64831 versus 64836. So you can see 64831, 64836. So 64831 is suture of the digital nerve, hand or foot, one nerve. And that's what we did. We only did one nerve. I'm not seeing any additional, just the ulnar digital nerve, digital meaning finger. So digit of the hand or foot. And then the 3-6 is the ulnar motor, but that's of the suture of one nerve, hand or foot, common sensory nerve. So was this a common sensory nerve? No, this was a digital nerve, and it was the 1. So one nerve, ulnar digital. So we do have one down here that's ulnar motor, so we could get tripped up there, but that's common sensory nerve. This was a digital nerve. So we want to make sure that we're using this code here, 64831, for suturing of one digital nerve. And then we're going to add on that F2 modifier so that we know exactly which nerve it was that was repaired. And in this particular case, that operating room microscope does not bundle, so we can code additionally for the 69990 for the use of the operating room microscope. So that's it for the endocrine and nervous system. Next time we will be going over eyes and ears, so be on the lookout and keep your ears open for that video. I will see you guys in the next video, and until then, just keep on coding on.